patient is a 43-year-old male who has presents with the chief complaints of recurrent episode of vomiting since 30 days, pain upper abdomen since 20 days. History of present illness. The patient was apparently well 1 month back, after which he developed progressively increasing early satiety and postprandial fullness. Then the patient developed multiple episodes of vomiting, approximately 2 to 3 episodes per day, approximately 30 to 40 minutes after solid meals, and more so at the night time. The vomitus was non-bilious, projectile in nature, and it contains digested food particles. The pain upper abdomen was insidious in onset, was dull aching in nature, it got precipitated after meals, was relieved by vomiting, and it was not radiating to back. Now, there is no history of hematochezia or melena. There is no history of fever and night sweats. There is no history of abdominal distension. There is no history of loss of weight and appetite. There is no history of palpable lump in the abdomen. There is no history of any PPI intakes or any pain which get alters with food intake. There is no history of jaundice. There is no history of bone pain, abdominal distension, and respiratory distress. There is no history of any psychiatric illness, and there is no history suggestive of steatorrhea. Past history. The patient has had recurrent episodes of upper mid-abdominal pain with radiation to back, minimum of 3 episodes in the last 2 years. The last episode took place around 3 months back. All these episodes were managed with conservative treatment, and none of the admission was for more than 3 days. And no history of any intervention was done during these episodes. Personal history. Patient is a non-smoker. He consumes alcohol regularly. The last intake was around 1.5 months back. There is no history of diabetes mellitus in this patient. The family history is not significant. To summarize, a 43-year-old male presented with recurrent episodes of non-bilious projectile vomiting since 1 month, with the past history of recurrent episodes of mild acute pancreatitis from last 2 years.
Go back to your first slide. Next. So what does this history suggest?
This history is typical of a patient of a gastric outlet obstruction, sir. The causes of which it is either a benign or a malignant, but my whole history has points which goes in the favor of benign as well as some are which in the favor of malignant also, sir. I cannot conclusively reach to a single diagnosis on the basis of history.
So for the sake of all the students, can you describe what is the typical characteristic history of gastric outlet obstruction?
It contains a large volume of vomiting, which is non-bilious, contains digested food particles. More so happens at the night time when the stomach gets full, and it might contain the food which has been taken even a day before, or even early in the morning.
Okay. Next. What do you think of this pain?
This is because of distended stomach, sir. When the vomit is, the pain gets relieved.
Okay. Next. Explain all the negative history. Why did you?
Sir, no history of hematochezia. Melena, they are suggestive of no mucosal disease, sir. No history of fever and night sweats. I was thinking lymphoma as one of the obstruction.
Hematochezia. Why did you ask for hematochezia? You are thinking of gastric outlet obstruction.
I meant hematemesis. Sorry, sir, I have by mistake written. I was thinking hematemesis.
Very, very unlikely.
Yes.
Very unlikely.
Sorry.
Hematemesis maybe, yes.
I was right.
Not hematemesis. Yes. Next.
And no history of fever and night sweats. I was thinking lymphoma as one of the cause of gastric outlet obstruction. So I included that. No history of abdominal distension. A patient who is vomiting as has pain abdomen, intestinal obstruction could be one cause, sir, but the vomiting in that is usually bilious. No history of loss of weight and appetite. I wanted to rule out any malignant symptoms. No history of any palpable lump in the abdomen. It could be either a per se a mass which has caused this obstruction, an entropyloric mass, or even a GB mass, sir. No history of any PPI intake. I wanted to rule out any history of any peptic ulcer disease in the past, which could have developed into a peptic structure now. And no history of jaundice, mainly because either some pancreatitis has led to any pseudocyst formation, which might be compressing the gastric outlet, as well as the CBD, which causes jaundice, or even any malignancy arising from the gallbladder, which could causing a gastric outlet obstruction. There's no history of bone pain, abdominal distension, distress, is to rule out any metastatic history, sir. And when I asked no history of psychiatric illness, bezoars were in mind, sir. There might be some bezoar related disease. And no history suggestive of steatorrhea. I wanted to rule out any chronic pancreatitis, exocrine insufficiency due to chronic pancreatitis, as patient has had multiple episodes of pancreatitis, sir.
Sorry, we lost connection. So what I was saying, that agreed that this is gastric outlet obstruction. What do you think is the cause of gastric outlet obstruction? Because that will decide what negative history we want to elicit.
Yes, sir. Sir, since this patient is having recurrent episodes of acute pancreatitis, so I am thinking a sequelae of acute pancreatitis has led to a gastric outlet obstruction as my first differential, sir.
So, how would recurrent acute pancreatitis cause gastric outlet obstruction?
Sir, if there is any pseudocyst formation which is compressing the entropyloric region, sir.
Any other?
Acute, if it is a acute, what it could be causing inflammatory stenosis or stricture at the gastric outlet, at the D1 part or the entropyloric region, that could be causing a gastro outlet obstruction. But this was a mild pancreatitis which relieved without any complications.
And when was the last episode of pain suggestive of acute pancreatitis?
1.5 months back.
And what is the chronological relationship between that episode and the symptoms of gastric outlet obstruction?
After the resolution of the last episodes of pancreatitis, 1 month after the resolution of the last episode of pancreatitis, he started developing these symptoms.
So that also doesn't fit in.
Yes.
If at all gastric outlet obstruction has to occur, it should occur during the episode of acute pancreatitis. It should not occur 1 month after the resolution, number one. Number two, if you are now saying that the symptoms of gastric outlet obstruction have been there for almost a month, so which means that the acute pancreatitis episode is continuing, because if acute pancreatitis has resolved and the obstruction was caused by inflammation and edema, then the symptoms of gastric outlet obstruction should resolve.
Yes,
Only
sir.
way they can test is, as you said, first thing, that if there is a pseudocyst which has developed following the episode of acute pancreatitis, that is causing the
Yes, sir.
obstruction. So let me go back a little bit. What are the common causes of gastric outlet obstruction?
There could be a benign cause or a malignant cause, sir. In benign, the most common cause would be a peptic stricture, which has been seen. In malignant, it could be a malignancy arising either from the entropyloric region or the first part of the duodenum, or in some cases, even the carcinoma pancreas arising from the uncinate process. That could present as a gastric outlet obstruction, sir.
Any other malignant cause?
CA gallbladder compressing upon the entropyloric region, sir.
You should, at least in North and West India, you should mention carcinoma of the gallbladder, which can infiltrate the first part of duodenum and can cause gastric outlet. It's not a common presentation, but it's not an uncommon presentation either. Okay.
Yes.
Any other benign cause other than peptic ulcer and peptic pyloric stenosis? Which could be the possible cause in this case also.
Chronic pancreatitis and duodenal stricture.
So I think rather than acute pancreatitis, inflammatory edema causing gastric outlet obstruction, which is persisting for 30 days, or a pseudocyst causing gastric outlet obstruction, more likely possibility is that since he has had recurrent episodes of acute pancreatitis, is it that he has underlying chronic pancreatitis? He is an alcoholic. chronic pancreatitis with superimposed episodes of acute pancreatitis, and the gastric outlet obstruction is a consequence of chronic pancreatitis, which is known. We will come back to that a little later. So it is with this background that the negative history becomes important. And in a patient with gastric outlet obstruction, I think you should, because here the history of PPI intake and any pain which gets altered gets diluted with the rest of the negative history. But this is an important key point in the negative history, because you want to say whether he has any symptoms of acid dyspeptic disease in the past, which is responsible for a benign gastric outlet obstruction. So that should get a prominent place in the negative history. Maybe I don't mind if you start with that. But he has no history of pain which is suggestive of peptic ulcer disease. Although he has upper abdominal pain, but that history is not suggestive of peptic ulcer disease. Okay. Jaundice. Why did you ask for jaundice?
Sir, if there's a pseudocyst which is compressing upon the causing gastric outlet obstruction, might also be compressing the common CBD also. So that could present with jaundice also, or even a CA gallbladder which is impinging upon the first part of the duodenum, that might also cause jaundice. So just to
So as we discussed, there are several causes of gastric outlet obstruction where, in addition to gastric outlet obstruction, jaundice may be present. CA pancreas, CA gallbladder, even a CA stomach or first part of duodenum can, if it is infiltrating posteriorly, can infiltrate the bile duct. Not common, but even peptic ulcer with posterior penetration can cause a benign stricture of the bile duct. Chronic pancreatitis can cause biliary obstruction if we are thinking of chronic pancreatitis. So it is important from so many other points of view. Next slide. Have you mentioned radiation to the back?
With radiation to back, yes, sir. Firstly.
Yes, you have. Okay. So here you should also mention whether there is associated retching, nausea, vomiting. These are the characteristic associated symptoms in patients who are having pancreatic pain, isn't it?
Yes.
Okay, next. Alcohol, here, if you are going to discuss a possibility of chronic pancreatitis, then alcohol history should be a little more detailed. What form of alcohol? You yourself may not be consuming alcohol, but you should know which form of alcohol contains how much absolute alcohol, how much gram of absolute alcohol he has been taking, for how long, what is the duration of his alcohol intake. So all this is important. And there is, I think, a WHO definition of a alcoholic. So anybody who takes alcohol once in a while, small amount, social drinking, is not an alcoholic. There is a definite definition of an alcoholic. Next. Next. Yeah, so here, since you are basing this summary on history, you should say 1 month with history of recurrent episodes of or history suggestive of recurrent episodes of mild acute pancreatitis. Okay.
Okay. Okay.
Let's just go back again. A few comments about the structure of presentation. This was content. Start from the first. Go back. Or okay, next. There is no space between a letter and full stop, comma, colon, semicolon. Okay, so after complaints S and semicolon, there has to be no space. Next, similarly, sorry, go back. You have given a space after A, but you haven't given a space after B. So after all these punctuations, there is always a space. Next. Why there is extra space between progressively and increasing? And don't use non-standard abbreviations. APPX is not a standard abbreviation. Similarly, after non-bilious, there is a comma. There has to be a space after the comma. Next. Before that, again, there is no need for a space between time and full stop. There is never a full space before a full stop, comma, colon, or semicolon. Next. Next. Go back. In the title, there is no need to put that semicolon. Semicolon is used when it is in the same sentence. If you are breaking the sentence, there is no need to put it. And whenever you mention any symptom, you have mentioned it earlier, but again, you should mention the duration. So you should have mentioned 20 days or whatever it is. Next. Again, spacing. Next. Next. And go back. Look at the size of the font of past history. Now go to the next. Look at the size of the font of personal history. It should be the same. There has to be, in scientific presentation, uniformity is important. In artistic presentation, variation is important. So these are not artistic presentations. These are not cultural presentations. These are scientific presentations. So same format, same font, same size, same color, unless you want to highlight something. If you want to highlight something, then you change the font, you change the color, you change the size to attract the attention of the audience to that point. Next. Next. Okay, next. Yeah, so there is a question in the chat. Let me take that. If the patient, now one request that please everyone join with your identity. Don't join as 1 plus MT2111. If the patient had GO since 2 months, he must had a significant weight loss history. So what did you say about weight loss? I missed that point.
No history of significant weight loss or loss of appetite.
Yeah. So how do you answer that question?
If you're saying that 1 month.
Not 2 months, it is 1 month, but still, so these are some benign conditions like corrosive stricture, gastric outlet obstruction, chronic pancreatitis, subacute intestinal obstruction, where patient may have loss of weight in spite of a normal appetite. So before you say that there is no loss of weight, you have to be sure. Otherwise, yes, the examiner will also ask you that a patient who has been persistently vomiting 2 to 3 times a day for the last 1 month, how is it possible that he hasn't lost any weight? So be sure before you say that there is no weight loss. These are occasions where examiner will cross question, and invariably it happens that the patient doesn't tell you what the patient tells the consultant or the examiner. That is invariable. Yes. So between these two, what in this case, what is your diagnosis?
The first diagnosis still for me is a pseudocyst causing gastric outlet obstruction. Sir.
So benign. You think it is a benign gastric outlet obstruction? And you should say that although the commonest cause of benign gastric outlet obstruction is a peptic ulcer with peptic pyloric stenosis, but in the absence of past history of suggestive of peptic ulcer disease, I am not considering that possibility. Although in the you should that it is possible that a patient with peptic ulcer may not give history of peptic ulcer disease in the past and can present for the first time with either obstruction or a major bleed or even perforation. It is known, but you would not like to make a clinical diagnosis.
Yes.
Why not malignancy?
So there are a few things which are not suggestive of malignancy. One is loss of weight and loss of appetite. And secondly, there is no any lump palpable anywhere in the abdomen, although that would be palpable in the pseudocyst also. But that is no thickening, no mass is as such palpable, and mainly the loss of weight and loss of appetite only.
But as we discussed, even benign gastric outlet obstruction can give rise to weight loss. It is basically loss of appetite. Patient with benign gastric outlet obstruction will have normal appetite, but patient is scared to eat. Patient doesn't eat because he or she knows that the moment he eats or eats a large amount, there will be vomiting. So they stop eating. Same thing happens with mesenteric ischemia. Same thing happens in patients with chronic pancreatitis. They know that eating is going to precipitate a problem. And that is why they don't eat, although they have appetite. So when you take the history, you have to be clear whether it is loss of appetite or whether it is decreased oral intake. Okay, let's move on.
General physical examination. My patient is lying in supine position with Ryle's tube in situ, which is draining yellowish color content. Otherwise, he is conscious, cooperative, well-oriented. The BMI is 20.2, his ECOG status is 1. There is no pyloric teres cyanosis or any other abnormality. The pulse rate is 76 per minute. The BP is 122/74. Respiratory rate is 15 per minute, and he is as such afebrile. Abdomens are on inspection. All quadrants are moving correspondingly with respiration. There is no visible scars, sinuses, visible engorged veins, peristalsis, or pulsations. The hernial orifice, there is no visible cuff impulse. On palpation, there is no tenderness, no mass is palpable, and there is no organomegaly. On percussion, the liver span comes out to be 14 centimeter in the midclavicular line. The flanks are tympanic, and on auscultation, there is normal bowel sounds heard, and no succion splash could be elicited. Respiratory system, there are normal vesical breath sounds heard. Bilateral air entry is equal, no crepitation or added sounds. The CVS examination is largely normal.
So what findings you were looking for in a patient who has an obvious history of gastric outlet obstruction?
I could feel a distended stomach, sir. We could hear a succussion splash.
Go back to your inspection. Again, see here the most important negative finding is no visible peristalsis, visible gastric peristalsis. So you should mention that separately, highlight it, and just don't say peristalsis, say no visible gastric peristalsis. Even the negative history or negative points in examination, when you mention, you have to mention them specifically, separately, highlight them, giving a pause before and after, so that I know that what you had in mind and you have looked for it. Next. Similarly, on palpation, the distended stomach may be palpable in a thin-built patient. You have to specify rather than just saying no organomegaly. And auscultation, yes, you have mentioned no succussion splash, but there was a rise tube in situ.
Yes, sir.
So again, here you should say that although there is a rise tube in situ, I don't expect a succussion splash, but still because even if you have a rise tube in situ and still there is a succussion splash, that is very important.
Yes, sir.
But if it is not there, it doesn't mean anything. So again, here you should, because by that time the examiner may have forgotten whether the rise tube is there or not. Okay.
Okay, sir.
Next. Yeah. So what will you do?
Okay. Sir, since the patient is in a gastric outlet obstruction, I would like to first admit the patient. Do a thorough lavage of his Ryle's tube, which is already been in situ for a day. And in the meanwhile, I'll start to hydrate the patient and get him investigated for his renal function and electrolytes.
Is he dehydrated?
No, sir. Clinically doesn't look dehydrated.
Go back to your general physical examination. There is no mention of hydration status.
Yes. Yes.
It should be there. Okay. It should be there. What else should be there in the general physical examination in a patient with gastric outlet obstruction?
Nourishment status. Whether is well nourished or not.
Theoretically speaking, can there be an observational finding in severe, prolonged, long-sleeping, uncorrected gastric outlet obstruction? What metabolic disturbances they can have?
They could have a metabolic alkalosis with hypochloremia and hypokalemia with hypocalcemia.
So what can be there?
Tetany.
Sorry?
Hypocalcemia induced tetany would be.
So there's no harm in mentioning that. Some examiners may kind of expect that you have looked for it.
Okay.
Okay. So why do you want to lavage the stomach?
Sir, if we in the long plan to do endoscopy, we might not get the good image, sir. And there is also a risk of aspiration. So we want to lavage the stomach, and once the returns become clear, then only we'll proceed for endoscopy.
Anything else? You said correction of dehydration and any other corrections required?
Electrolyte imbalance might be there. That is,
So you should say that I would clinically check the hydration status of the patient, look at the urine output if it has been recorded in the last 12 or 24 hours before the patient has come to me, or at least I will monitor it prospectively. I will look at the metabolic status. So what important investigations you would like to look at?
One is the blood gas analysis, serum electrolytes, and serum creatinine, the renal function test.
Let's see.
The blood gas analysis is not available. This is the complete blood picture, which is grossly normal, sir.
Can the hemogram give you any clue?
Yes, a hematocrit would be raised.
So,
That is
high
also
hematocrit can suggest that the patient may be dehydrated.
dehydrated.
Okay, next.
This is the serum creatinine is largely normal. The electrolytes are more or less normal. There are no as such gross abnormalities in the sodium or potassium levels.
So suppose this set of investigations is given to you. In addition to commenting on the reports available, you should say that you would have liked to have this also. So for example, you would have liked to have hematocrit, you would have liked to have arterial blood gas to look at the metabolic disturbance. Okay, fine. So fine, he's been his dehydration and metabolic disturbances have been corrected. The returns are clear now. What will you do next?
Proceed with the endoscopy, upper GI endoscopy.
Okay, let's see.
This is one ultrasound that patient had, so just included.
Would you have done an ultrasound first?
No, sir. There, if we are suspecting a malignant gastric outlet obstruction, we might do ultrasound to rule out any gross liver mets or gross ascites. Apart from that, since it is a benign case, I could directly go ahead with the endoscopy.
Yeah, so if you are thinking of a malignant gastric outlet obstruction, there would not be an objection to doing ultrasound. But if you are thinking of a benign gastric outlet obstruction, there also, if you are thinking of chronic pancreatitis as a cause, you can say that it can show some findings there.
Yes, sir.
So there's no harm, and ultrasound being a non-invasive investigation, I don't think there can be any objection. There is a comment from Dr. Jasmeet Singh that is ABG needed? Yes, we've already discussed that all patients with gastric outlet obstruction should have a complete metabolic workup, which will include an arterial blood gas analysis, which was not there in this case. Yes, you are right. Okay, so ultrasound shows anything significant?
The stomach is grossly distended, sir. Only that. But they have commented the pancreas is normal.
They've mentioned something else, duodenum.
Yes, with the normal caliber of second or third part of the duodenum, the obstruction is likely to be in the first part of duodenum as per this ultrasound report, sir.
Okay, okay. Next.
So this is the endoscopy.
Yes.
Since the patient is inadequately prepared, that they are still showing the stomach is full of food. But also they have seen the first part of duodenum to be grossly dilated. They could not tell exact location of obstruction or if there is any stricture or a lesion from where they could have taken a biopsy. Their gross impression is still D2 obstruction.
So how do you interpret this endoscopy report, considering all the differential diagnoses that we have considered?
So it rules out any entropyloric or duodenal malignancy. It is normal. As such, there in the first part of duodenum also there is no stricture, which we are expecting mostly in a peptic stricture patient. And as such, there is no indentation on any walls given, which could be due to a pseudocyst. There is a obstruction which is given in the level of D2, and we'll have to do a further investigate to look at the cause of obstructions.
So is this the characteristic endoscopic finding in a peptic pyloric stenosis?
No, sir.
It is not, because they haven't, D1 is grossly dilated, which is very unusual. There is a peptic ulcer, then D1 will be grossly deformed, shortened, contracted, isn't it? So it rules out CA stomach, it rules out CA duodenum, it rules out probably a peptic stricture. And also there is no extrinsic impression. If it is CA-GB infiltrating first part of duodenum, you will see an extrinsic bulge on the posterior or anterior-superior part of the duodenal bulb. If it is CA head pancreas, you will see a bulge on the medial wall of the duodenum. If it is CA uncinate process, you will see the bulge in the distal part of D2 or D2, D3 genu. And actually, A CA uncinate process is a situation which will cause gastric outlet obstruction, but the vomiting will be bilious because it is post-papillary obstruction. And these patients may not have jaundice. In CA head pancreas, when there is gastric outlet obstruction, most patients will have obstructive jaundice because the bile duct also is obstructed. But CA uncinate process is a situation where patient will have gastric outlet obstruction with bilious vomiting and may not have jaundice. So there is again a question from Jasveer. What are we going for direct invasive procedure if we have non-invasive procedure like barium? Okay. So answer this. Would you like to do a barium?
Sir, upfront, I would like to do a upper GI endoscopy only. It gives the additional benefit of taking a biopsy if there is any stricture or any ulcerated mucosal lesion. That is not there in a investigation like barium. Even it helps in therapeutically, it can also benefit, sir. If we are suspecting a peptic stricture, medical gastroenterologist might do some therapeutic intervention to like a dilatation or something, or balloon dilatation, which could help resolve the stricture in the first go as well.
Yeah, by and large, today there is very little role or very little place of a barium contrast study as opposed to either an endoscopy or a oral contrast CT scan. The only situation where barium would be or may be indicated as the first investigation, one is in a patient with dysphagia where you are thinking of a motility disorder. And second is a corrosive stricture before an endoscopy, as you rightly said, that some endoscopists may want a barium swallow as a roadmap to tell you how much is the narrowing, whether there is any angulation, whether there is any pseudo-diverticulum which they would try to avoid a perforation. But in stomach, a barium meal study hardly ever today probably will be indicated. Any situation, Ajay, you can think where we would do a barium? Yeah. Yes. CT.
That is always good.
Yes.
I would ask Jasmeet that do you think that this endoscopy report is complete from your side? Or if you were doing this endoscopy, you would have looked at something else also?
Anything else? Dr. Ajay wants to know whether the endoscopist should have looked at
or reported it. If saying a complete or just a statement that B2 obstruction is not complete, I would like to know how is the report. Is it circumferential? Is it non-circumferential obstruction? Is it having a band over there? Is it having a type of picture over there? Or definitely you have just mentioned that is there an extensive compression? So that will show mucosal. At least these things should be mentioned over there. I think it is obstruction or not a complete obstruction. How can you differentiate between a complete obstruction and an incomplete obstruction or an endoscopy?
If they're able to pass the scope or not, sir.
Yes. So only thing the problem with this is that a normal endoscope is a wide diameter endoscope. So they cannot pass this wide diameter endoscope, but they can see an opening over there, which is possible, which can be possible. At least some content is going beyond it. So obstructed content which are being blocked by the partial obstruction, they tend to pass beyond it. That shows that it is possible. So in that content, they should be able to see the mucosa.
There was another positive finding in endoscopy.
A polyp in the upper part of the esophagus has been detected.
You didn't comment on that. You can't ignore a finding. You may not. So you should say that this is an incidental finding, but I think it is of no consequence. Okay.
Yes.
You have to mention it. Okay. Next, what will you do?
I'll do a contrast and a CT scan of the upper abdomen, sir.
Why?
To look for the actual cause. Still, I'm not sure about the cause, whether it is an intrinsic compression, extrinsic compression, or if there is any malignancy, or what actually is the point of transition, where it is ending. That I don't know. So I think I'll get that information from a CT scan.
The point of transition is important in intestinal obstruction. Here, is it going to change? More important is, as you rightly said in the first sentence, that you want to know the cause. The absence of a bulge or an extrinsic impression doesn't still rule out a malignancy because it may not be producing a mucosal bulge. So yes.
final treatment will be giving, that will also depend at the point of transition, sir. Like if it is a benign and we have to bypass it, whether we'll do a gastroenterology or a duodenogenostomy, that will give us some. If there is ample duodenum available, we might do a
Okay.
duodenogenostomy.
Okay. Yeah, I agree. Fine. We have a CT?
Yes, sir.
Yes.
So, sir, these are the axial images of the CT upper abdomen. The first three images are of non-contrast scan, and from the fourth image, we start with the contrast scan. The striking thing is that
Not first three images, first three rows.
first rows. Sorry,
So in any CT scan, there are rows and there are columns. The horizontal are the rows, vertical are the columns.
Yes.
Yes.
So from the fourth row, we start with the contrast scan, and the grossly we can see
So
the
you don't
stomach.
want to look at the non-contrast. Why have they been done?
So there are very limited images. I can look at that also, but they're just given a one row, and there are not much images, not much sets available, sir. In the contrast, we are giving the holes, cuts, and there are a lot of sets available.
In this setting, since we were considering the possibility of a chronic pancreatitis with acute on chronic episodes,
Yes, sir.
you should
Yes,
look at the plain cuts also and comment whether you see any calcification in the pancreas or not.
yes, sir. Yes. Okay. So the stomach in this hole is grossly distended, sir. And even we can see the first part of duodenum here is also distended, which is abutting the, which is next to the GB. And this is the first part of duodenum. I'll move on to the next picture, sir. So here it is. We can see the D1 part is distended. The D2 parts is also distended, but in the here it becomes collapsed, sir. So it is the part which is, and the, I'll have a look at the pancreas, sir. I think it is in the previous image. Here it is, sir. We can see the pancreas. The pancreas in the head and the tail looks normal, but in the body part, there seems a bit atrophy of the pancreas, sir. Although I could not see a dilated PD. Also, moreover, there is no fat stranding in the duodenum or any significantly enlarged lymph nodes, sir.
Yeah, Dr. Kotecha from Tanzania says that it is always better if we can see the video rather than
Yes.
static film. Also, static film, when you have copied the image, you have caused a distortion. It is appearing as if it has been vertically compressed. That should not happen. So go back to the second part of duodenum, which is dilated. Yeah, if you see the first row, in the duodenum, you can see a food fluid level.
Yes, sir.
I think it is food fluid level, but whether there is a focal thickening of the posterior wall of second part of duodenum, I can't say based on this. But it appears as if, because it is direct, it is a plain horizontal. So probably it is a food fluid level. And then the point which you were saying, transition, you can see transition is between the first and second image in the second row. In the first image, this one is still dilated. After this, you don't see the lumen. So that is where there is. And you have to say that at this point where the transition is occurring, there is no mass in any of the adjacent area. Either in the wall of the duodenum, there is no mass, there is no focal thickening, there is no polypoidal lesion to suggest any duodenal malignancy. And if there is any pancreas adjacent, and in the upper cuts, you should have commented on the gallbladder also, because that was one possibility we were discussing. So when you are looking at the image, you have to keep in mind what possible differential diagnoses we were considering and rule them out one by one.
Yes, this is one image, sir. Here also, it is better visible.
Yes.
This is the first part, still distended. The gallbladder is there. It looks contracted, looks normal.
So if you see the last row,
Yes, sir.
first image, if the last row, first image, again, that level is seen, but here it is vertical. So maybe this is taken in the supine position, but here it is shown. And if you see the second image, again,
Yes.
it appears as if there is some thickening of the wall.
Yes.
Here it appears like a thickening. So there is a possibility that there is a mural thickening in the wall of the second part of duodenum. But obviously it is papillary because the vomiting is non-bilious,
Yes, sir.
not beyond the papilla. It is only the first and the proximal second part of duodenum which is dilated. And that is why what Dr. Ajay was saying and asking you becomes very important, that at the point where there is obstruction, the endoscopist has to examine and mention whether the mucosa is normal or not.
Yes,
So
sir.
suppose the endoscopist mentioned that the mucosa was normal, there was no growth, there was no ulcer, there was no nodule, but in the CT scan you are seeing thickening of the wall of the second part of duodenum at the point of transition. What comes to your mind?
Any submucosal lesions, sir?
So there is a thickening of the wall, but the mucosa is normal on endoscopy. Wall thickening on CT scan, but mucosa is normal in endoscopy. What do you start thinking?
There could be any submucosal lesions, sir, such as a lymphoma.
Yeah. So young patient, history suggestive of malignancy, imaging shows diffuse circumferential thickening of the wall. Endoscopy shows mucosa is normal. Repeated endoscopic biopsies are negative. That is the situation where you should start thinking of a possibility of a lymphoma. Because the other possibility is tuberculosis. But in tuberculosis, mucosa being normal is very, very unlikely. You will see some ulceration, some nodule. So normal mucosa, wall thickening, you should immediately start thinking of a possibility of a lymphoma. Because as we have discussed, this is an unusual site for a peptic stricture or a peptic. Peptic is usually pyloric stenosis.
Yes, sir.
The first part of the duodenum is usually not dilated. So it is little unusual for a peptic gastric outlet obstruction. And since we are seeing some thickening in the wall of the duodenum, you may think in terms of a possibility of a lymphoma. Any other investigation? ये जो last row की second image है, point करो cursor से. Yes, this one. It appears as if there is a thickening in the wall.
But then it should be seen in the cross-sectional image also.
So in the axial, I thought it is a level. It looked like food. Yeah. Here I thought it is food and fluid level. So I'm not.
But thickening level we have in the standard fluid
Yes,
level.
it should not look like this.
Remember what is
Yes.
only okay. This area on the medial side also is this extent is not.
Yes. Yes. So Dr. Ajay is pointing out in the first row, third image, if you see that horizontal on the medial wall of the duodenum also, it appears as if there is some thickening.
Yes,
So
sir.
that is suggestive of thickening. The horizontal level may be food level, food and fluid level. So we have a suspicion that there may be a thickening of the wall of the duodenum. So what will you do now?
Try to do a repeat endoscopy, sir. The first endoscopy had a lot of food particles in it. So do a repeat endoscopy.
The area where there is thickening, there is no obstruction.
Obstruction is
The area where there is obstruction.
there is yes, yes.
So
Yeah, I agree with you that a repeat endoscopy to look at the mucosa at the site of narrowing is important. Has it been done?
No, sir.
Now he has already done an endoscopy once. So now will you ask your endoscopist to add something else to his armamentarium to help you out?
Suppose your endoscopist says, no, I have done a good endoscopy. I have seen it. Well, mucosa was normal. Then,
Since we are suspecting a lymphoma or submucosal lesion, we request him to do a deep biopsy, sir, or a well biopsy or a deeper biopsy. We'll request him to do a deep biopsy to look
anything
for a
else before
lymphoma.
you attempt a biopsy, which will help you, guide you? Any
EUS,
investigation?
EUS, endoscopic
Sorry?
ultrasound, endoscopic
Yeah.
ultrasound.
That is what, see, he gave you a hint also, anything else in your armamentarium. That means he is trying to point or hint you towards a gadget, not a
Okay.
procedure. You have to read into the examiner's mind and examiner's words also. Okay? So whenever you have a wall thickening and mucosa is normal, or whenever you have an extra mucosal lesion, say GIST, or say varices, or collaterals, then endoscopic ultrasound is a good investigation because it evaluates the extra mucosal or submucosal lesion and helps you to target your biopsy. Endoscopic ultrasound can be used as a guidance either for a fine needle aspiration cytology or even a core biopsy. And you can do a targeted biopsy. So I think if the endoscopy is not done by an expert or experienced or interested person, then yes, definitely a repeat endoscopy. But if it has been done by your endoscopist and you are happy and satisfied, then the next investigation will be an endoscopic ultrasound. And it is very important, these two conditions, which are a mimic of any malignancy, tuberculosis and lymphoma, because the treatment plan is totally different. If you diagnose lymphoma or tuberculosis today, for lymphoma, surgery is almost never the first choice of treatment. In all GI lymphomas, chemotherapy is the first choice of treatment, unless there is a complication.
Yes.
Is there anything you would like to add on the CT scan findings that you already did? Anything else that you would like to add? You would like to look into? I'm telling you, you already got out of 100, you already got 10 marks. 10 marks, can you add something else to get those 10 marks also to your mark sheet?
Considering the differential diagnosis that we are considering.
On CT scan, you have a CT scan in front of it. Read something else.
So it's not audible, sir.
I think you have to speak.
Idhar aa jaao. Come. Dr. Ajay is asking that in addition to what we have already seen and described on CT scan, anything else to get you some bonus marks?
You mentioned
In the scan? In the CT scan?
Yes, on the films which you are seeing.
Okay.
Okay, let me say that you have to say no.
The pancreas is most or less normal, sir. There is just mild atrophy in the body of pancreas seen. Though that
important should be added to your finding that I am not seeing this, which is important now. It is not seen.
CBD is not dilated. CBD is not dilated.
Fine, CBD is not dilated is not that. You are having a differential of malignancy, a differential of lymphoma.
No significant lymphadenopathy.
Lymph nodes.
Those 10 marks.
Okay. You should have mentioned that there are no enlarged lymph nodes anywhere.
Yes, sir.
Okay. Yeah. And you could even say no hepatosplenomegaly if you're thinking of it.
Yes.
Okay. We have any other investigation?
No, sir. He came up with these investigations.
Okay. So, suppose endoscopic ultrasound doesn't show anything significant. No wall thickening, no mass, and obviously the mucosa is normal.
Okay. I'll just do a tumor markers also, sir, to rule out any chance of malignancy.
Which tumor marker?
CEA and CA19.9.
Tumor markers are a diagnostic investigation.
Just helps with.
You're not seeing a mass lesion in the pancreas. You're not seeing a mass in the duodenum. You are not seeing a mass in the gallbladder. I don't think tumor marker is going to help you. Tumor marker you do when you are either suspecting or you have made a diagnosis, and that also is mainly for prognostication, mainly for follow-up. They are hardly ever used for diagnosis.
Yes.
At least in the GI and HPB.
So since there are not anything significant in the malignancy side, we are not still getting. Can think of bypassing this lesion, sir, surgically.
Yeah, so I don't think we now have the time to discuss the management, but maybe you can, if you want to continue with this case, the management, you can fix up a time with Dr. Anand, and we can continue with this. Dr. Kotecha says for a lymphoma and considering the chemo, how does alleviate the GO? Yeah, so that's the point I was saying that we will discuss, that if it is lymphoma, how do you manage? Because there is gastric outlet obstruction. And if it is just a benign gastric outlet obstruction of no specific cause, then how do we manage? What kind of a bypass? What are the issues involved? But in a line, do you want to answer that question? But suppose it is a lymphoma and you have to give chemotherapy, how about gastric outlet obstruction?
Sir, I can try doing the nasopulmonary drainage, NJ drainage. I can do a nasojejunal tube, and in the meantime, I can give chemo. It tends to resolve after chemo, sir.
You mean gastrojejunostomy, you were saying?
No.
NJ. Yeah, agreed. So we know that lymphomas are known to, within inverted comma, melt with chemotherapy.
Chemotherapy.
And one cycle of chemotherapy can relieve the obstruction. So either you do that, or as you rightly said, that you place a nasojejunal tube, and that is where, again, what Dr. Ajay said is important, that whether they could see an lumen through which at least something was seen, but scope could not be passed, or is it a complete obstruction? Even in what appears to be complete obstruction, a good endoscopist or a radiologist can pass a guide wire. And once they have passed a guide wire, then with little bit of balloon dilatation, they can always place an NJ tube, which can be used for feeding, and then you give chemotherapy. And as I said, with 1 or 2 cycles of chemotherapy, the tumor will should respond and the lumen may open. So in lymphoma, to relieve temporary relief of obstruction, surgery today is not indicated. You can always do it with a tube or a stent or whatever you want to do. And then
I have one doubt, sir. Can I, in such case where the obstruction level is at D2, is there any role of endoscopic dilatation or balloon dilatation? Does that work at D2 also, sir? We have only seen in the entropyloric region it's helping.
Yeah, there are reports where people have used a non-surgical method to, as you are saying, endoscopic dilatation, and then manage the ulcer disease with the PPIs and all. Obviously, if you've ruled out any specific disease, that option is always there.
No. Yes. Sir, I was not able to hear the last line, sir. Please.
Am I audible?
Yeah, now you're audible, sir. Yes.
So you have placed a nasojejunal tube.
Okay.
Now, second most important thing that you will do now, you start feeding, patient is able to take a food. Patient is having obstruction in D2,
We'll now aspirate now. We'll come to know if the bile is coming, we can start feeding, sir.
The bile is coming out and you start feeding. What will happen to the gastric contents?
There is one aspiration port also, sir. So we can.
You have to place the classical tube, which is having one aspiration port in the stomach and one feeding port in the jejunum. Or
yes,
you will have to place 2 tubes, one in the stomach to decompress. If you are using a routine nasojejunal tube, then you have to place 2 tubes.
Okay, I think we will close the session. Thank you, Jasmeet, for presenting. Thank you, everyone.